very important topic, left main PCI, the historic perspective and from concept to state of art. Left main supplies almost 80%, 75 to 80% area of the left ventricle. And when it is dominant vessel, left dominant vessel, it supplies almost more than 90% area of the left ventricle. So it becomes so important for us if we want to consider for the therapy. Some anatomic factors which are very important, the length and the short. Short is less than 8 millimeter and long is more than 15 mil. And elasticity is one thing which we have to remember. So we need a higher radial strength for left main because it's highly elastic. Elastic recoil is bound to be there. So of all the injuries which are done, 5% we can have a left main disease and 70% associated with triple vessel disease. 9% isolated left main disease and 5% patients will have STEMI and 10% will go for CABG immediately. If you leave them on medical treatment and lesion is 50%, the survival is 40% for 3 years with medical treatment alone. And if the lesion is 50 to 70%, the survival is 50%, 66% mortality. With this. So it's very high mortality. Therefore, medical treatment is not an option. So we have to consider revascularization. So it's either by CABG or PCI. Now, looking at the left main, it looks like a very attractive target, very easy to engage and just go in with the wire and stand and do it. But it's larger caliber, close proximity to aorta and low tortuosity. It's attractive. But there are several issues which we all know. And just now I highlighted one, the large area of myocardium is under jeopardy. So when have we started, how it evolved, the left main plastic? Initially from in 77, Grunzig did the first left main angioplasty with balloon, which was not successful. At that era, there was no stent. Antiplatelet agents were very basic. There was not much enhanced antiplatelet activity with those agents. And then several studies done and said that angioplasty is contraindicated till 1993 until we had a stent. Then feasibility was come. Then 93 to 2003 only consider them for particular subset where patient is not suitable for CABG due to high ST score and the patient is in the acute coronary syndrome. These are the two major indications that time from 93 to 2003. 2003 we got the DS era and in that there are several trials done. With that trial, everything going through, so 2009 to 11 indication for left main PCI was 2B by various guidelines, ASCC, AHA, and 2A later after 2011. The Park et al. Did the major study in the beginning and he reported that PCI to LMCA is not an inferior option to CABG. And then, of course, the syntax score has come in the vogue and we know low and intermediate and high syntax score. The Mackey is the highest in high syntax score, more than 33, where these patients are not suitable for PCI. Then meta-analysis study was done, DS versus CABG, 24 studies, 14,000 patients. And for the first time, 6 studies reported that PCI is favored in left main. So what is the problem? Problem is the large area of myocardium under jeopardy, so there is a time limitation in doing a procedure and technical challenges for deploying 2 stents, particularly. Single stent, no problem. The long-term results is thrombosis and restenosis, particularly when optimization was not available. So under expanded stent or Malapose stent had several issues. Then we have anybody who has to choose a patient to decide whether they want to do left main PCI or not must look at the risk. If the risk is low, you can definitely do, but high risk, it should be planned elective PCI if CABG is turned down for some reason. So these are some of the important criteria that we must remember. If there is a calcium, the syntax score is high. If there is thrombosis, poor LV function, all this becomes very high risk, and we should not consider PCI in this patient, even when they have a large RCA, because large RCA is one of the criteria to consider PCI to left main. So we must choose a low branch which has a low risk. If the circ is the main branch, if it is of smaller size and length is not much, we can ignore and do a single provisional stenting to left main. So we basically divide them into a low risk and high risk PCI in left main depending on the clinical scenario. This is the syntax score which we all know. Now overview, there are several trials, but there was some controversy after the Excel trial results were presented. And then individual patient data meta-analysis was done by individual operator. And these operators, they've studied all these cases which were done in this DS era in various trials. And this was the breakup point for surgeon and the cardiologist, that there was a protocol definition of MI which was showing inferior, the CABG has more MI than PCI. So this was not acceptable to surgeon. Surgeon broke away, and that appeared in BBC. So the group from Academic Research Organization from Brigham and Women, Harvard Medical School, Braunwald is a part of it, of this committee. They evaluated this lesion, each and every case individually. So 14,000 cases of PCI of left main was evaluated individually by them, and it was reported that absolute risk is 0.2% per year. So 10-year mortality is numerically little high than the CABG, but statistically not significant. So protocol definition, this is a very important difference, that in PCI, MI 3.2%, but in CABG 4.7%. But when universal definition of MI was applied, the thing reversed. So CABG has less MI and PCI has more. But that is not, the difference is not statistically significant. So the summary of this group, Academic Research Organization, they said that the PCI has less early stroke, and CABG has spontaneous MI more. CABG has less spontaneous MI and repeat revascularization, which are more in PCI arm. So 2021 ACC/AHA came out with the guidelines saying that class 1 for left main and class 2A for left main PCI, for CABG class 1 and PCI class 2. Then FAME trial results, FAME 3 trial results came comparing the angio-guided versus FFR-guided or physiology-guided PCI, and it clearly showed that repeat vascularization remarkably reduced, and you can see the differences, but same happened in CABG arm too. So that difference continued to remain. So her team definitely has a place to decide, particularly when it is high syntax score or intermediate on a higher side. EBC has produced ethos, which is, we all know EBC is a European bifurcation club. They said keep it simple, safe, limit the number of stents. So what ultimately they are saying is prefer provisional, not two-stent strategy unless it is very necessary. Only when the operator is very expert and experienced, then two-stent strategy is fine. So this was the ethos of Bifurcation Club, and it is carried forward in the practice. This was practice impacting. So provisional, how do we do it provisional? That I will cover in detail. We can escalate to stenting or kissing balloon depending on how we have the flow. And then EBC consensus statement suggested that elective true stent should be reserved only for experienced operator. So this algorithm has come that where to do two stent and where to do a single provisional stent. Two stent, very clear that if the lesion in the side branch is more than 70% and the length of the lesion is more than 10%, it's a complex lesion, better to go for two stent strategy elective, not ad hoc, anytime. It has to be elective, associated, and also must be with the imaging. Other side, if the lesion is not complex, simple, then side branch access decides whether two stent or single stent. Side branch access is very, very important. Then Asia specific also came and they also gave the similar consensus statement saying that it has to be decided on the side branch access. What is so different in stenting of LMPCI? One is the caliber discrepancy because we choose the stent as per the daughter vessel caliber. And the left main caliber and the daughter vessel caliber, if the difference is more than 2 millimeter, then we have to decide which device to use, which stent to use, which will deliver this more than 2 millimeter expansion. Second is bifurcation angle, very important. The narrow angle has several issues. Provisional is almost quite risky. In more narrow the angle, more the risky of provisional. We all know that. Iotaosteal we have just discussed it in greater detail today. And the main thing is elastic recoil of the stent, which is a main factor in while. So you need a good radial strength of the stent. With the reducing strut sizes, radial strength has definitely come down of various stents. So Megatron was one such stent which is very synergy. Megatron is definitely a choice for higher radial strength for left main, and it has an expansion of more than 2 millimeter from the reference vessel diameter. And of course calcification, then we have to consider the various tools that can debulk the calcium from the left main so that devices can be advanced and can be deployed and stent can be expanded appropriately. So how do we do a provisional? That was the, so yet you wire both the vessels and deploy the stent, jailing the side branch wire because it acts as a marker. And if there is some issue, and then do a pot. Pot is very important because it gives a typical normal local anatomy. It maintains from higher size to lower size, the tapering of the left main. So proximal top pot with the bigger size balloon, appropriate size balloon, NC balloon is of a great importance because it opens the strut of the side branch and gives a tapering shape to the left main. So the anatomy which is original is able to maintain. So in provisional, what is important? After we deploy across the proper pot, the pot balloon should not exceed carina, up to carina. It should be a NC balloon and do a high pressure pot and optimize with imaging. That becomes very vital even in provisional approach. So if you have a reduced flow in the side branch after doing a provisional, then do a FFR. FFR is negative. You can just do kissing and leave but kissing is an option left to the operator whether he wants to do a kissing after provisional or not. How to protect the side branch? There is a balloon technique which is available. There are two types of technique. One is inflated balloon underneath the stent into the side branch, and then second is deflated balloon in the side branch, and part of the balloon is in the below the stent, and deploy it and then pull out the balloon. This protects the side branch because it changes the angle basically. So if side branch is compromised and FFR is positive, then you should not hesitate to escalate to two-stent strategy, and by default, the bailout strategy is most of the time tap. And that is what it shows, that these are the bailout strategies: tap, reverse crush, or cullet. So if we want to do a kissing for a provisional stenting, then the wire should go through a distal strut. That becomes very important. You can see it in the diagram, because that maintains that opens up the side branch very well and allows the flow to be rheologically physiological. And wire wrap is another issue that technically we all know. Wire wrap can be there, and it can be easily identified that if your device is not going and whatever wires are there, they are coming back into, so then that's the time your guiding is backing out, then that's the time you realize that it's a wire wrap. How to prevent it? Wire the most angulated vessel first, avoid excessive rotation of the second wire, and keep the wires separate during the PCI. We all use, good size towel to keep the second wire underneath, under a weight, so that it doesn't rotate on its own while you handle various devices in and out. So what are the issues anatomy wise? Issue is either you can have a Y-shaped bifurcation or you can have a T bifurcation. The angle in LAD L6, that's the normally we look at. An LAD angle, if it is more than 90 degrees is T, less than 70 degrees it is Y-shaped. In Y-shaped is further subdivided into Y1, Y2 and Y3. This is very important for anatomical, because depending on the anatomy, you can choose the technique which is suitable for handling a bifurcation lesion. So if you have in Y1, it is usually equal size branches. LAD L6 are of equal size, and if you add 2, it is equal to that of LM size. Whereas in Y2, one of the branches is bigger size, and Y3, all three left main LAD L6 are of equal size. That is where we consider culotte as the most suitable technique. But now, over a period of time, only 3 techniques have remained in vogue that I am going to talk about. And this is what we say, that T for the T-shaped, and T options are various. We have spoken about it, how to cover the left circumflex ostium. For that, you need a tap technique, so that part of the stent 1 or 2 millimeter is into the left main vessel, left main. So if you have a true bifurcation lesion, that is 111 or 101 or 011, then better to consider upfront 2-stent strategy, and preferred is double kissing crush, decay crush, because results are very good. And it ensures the side branch access is relatively easy. And for non-true, we can consider the provisional stenting. The result, RCT was done, decay crush 5 RCT, comparing provisional with the decay crush. And decay crush is definitely statistically superior, significantly. So decay crush has 7 steps, we all know. I don't go into detail of these. But advantage with decay crush, we have already spoken, that it allows access to the side branch easy, and it also gives opportunity for double kissing, so that every time the normal anatomy of the vessel, local native anatomy of the bifurcation is maintained. But disadvantage is we cannot plan it in a provisional stent. If we do a provisional stent, we cannot do decay crush. So it has to be upfront. That is the disadvantage. And multiple steps, of course, is time consuming. So what is different from the classic crush, decay crush, what is different? The two kissing, 2-time pot in both, and passage of guide wire into side branch from the proximal cell in decay crush, whereas in the mini crush, we can wire it through the distal. So ultimately, what is EPC consensus saying? It's saying that consider provisional for every lesion, and if necessary, then only consider complex two-stent strategy, and that is when the results are not good. How angulation affect? Technically, if it is Y-shaped, the access to the wire is easy, whereas in T-shaped, access to wire is difficult. But plaque shaped and carina shaped is lot more in Y-shaped as compared to. So most of the vessel closure of the side branch occurs in Y-shaped carina in provisional. And 75% is Y-shaped, 25% is T. Another issues with the bifurcation of the left main lesion, because of the angle, acute angle, there is a fatigue of the stent over a period of time, and that due to shear stress, due to rheological problems, and that also gives a late stent thrombosis and other complications. So unique consideration for left main, we call it a different animal. One is large side branch, and second is usually it leads to a lot of ischemia if there is acute closure of the side branch. And LM bifurcation, where proximal and originates, the interaction between the guide wire and leads to deformation of the stent sometime. If we are not careful about pulling out the gel wire, guide can suck in and deform the left main stent. So when you do a provisional, MLA of the side branch is reduced. And if it is significantly reduced, 10% reduced in all the cases, but if it is significantly reduced, compromising the flow, then of course you have to consider kissing balloon and do, if necessary, FFR and decide about the second stent. So narrow angle again is an issue which leads to a greater reduction in MLA and EM area of the side branch ostium. So once the ostium of the side branch after the provisional stent is occluded, then wiring in Y-shaped, you have to wire carefully so that you can do a kissing, particularly from distal strut. So what is the evidence of kissing balloon? Evidence shows that it is provisional, it is neutral, neither benefits nor cause harm. But in two-stent strategy is highly beneficial because it maintains normal anatomy and allows the rheology physiological. So optimal final kissing, how do we do? We have to choose short balloons, non-compliant balloon, as per the distal vessel diameter and expand it for 20 seconds. But the point is, here we have to expand first the side branch balloon at a high pressure and make sure that whatever metal is available, the 3-layer later metal which is available in the ostium of the side branch LCX is compressed completely before we do a kissing at a high pressure. And this is the advantage which can reduce the stent area, it can increase and it can reduce the thrombosis. So two-step, as I said, two-step has a distinct advantage. It produces a larger and the circular lumen. The pot idea has come from visible heart, in which we can see, like an angioscopy, we can see the entire stent in a video. And of course, the 3D OCT also helps in this, saying that pot, if it is properly done, just before the carina, at high pressure with appropriate size and balloon, it gives good result. Then these are various techniques which we know, two-stent technique, and various techniques which are used in Y-shaped and T-shaped, we all know that. But about the provisional, initially we were doing only T, but now we do TAB because T leaves the ostium uncovered by the drug-eluting stent, whereas TAB makes it sure that the ostium of the circumflex is fully covered, and that reduces the restenosis, which is Achilles heel of the left meningeoplasty, that is ISR coming back in the left man, in the L6 ostium. So, and decay crush and mini crush has become favorable. So, if anybody who wants to do left main PCI, he must be familiar with three stenting technique: decay crush, mini crush, and TAP. So, these, if you know these three techniques, and if you've done enough procedure, then you're good for it. Sometimes we land up with the borderline lesion. In borderline lesion, we have two approaches in left main. One is FFR, of course, physiology, and second is imaging, IVUS. That can also give us, and because IVUS study has been done and it has shown that if your FFR is 0.75, it tallies very well with the left main MLA of 5.9 millimeter square. So 5.9 becomes the cutoff point for this. And when the trials were done, they have found out that the MLA cutoff should be 5.35, the average of all the MLA size. So what are the cath lab questions? Optimization. That is the main thing that in the cath lab, that all our stents are well opposed and they are in proper size. There is no under expansion of any stent. There is no malposition of any stent, particularly in left main, because thrombosis in left main means mortality, calamity. So the imaging becomes absolutely mandatory when you do a left main PCI. And we have two modalities, IVUS and OCT. OCT advantage and IVUS advantage both have a calcium score, so we can decide about whether we want to use any tool to debulk calcium, and we can decide about the tool, whether it is atherectomy or a simple IVL balloon or simple cutting balloon will do. And this, so many imaging studies have reported that there is definite reduction in MACI and also the mortality if you do imaging-based PCI of the left main as compared to the just angio-guided. And these are long-term study, 5 years and 10 years study, and all of them show about 40 to 50% reduction in mortality, and the benefit continues to increase. MACI is reduced, and this shows that the benefit continue to increase over a period of year 360 days. The gap between angio-guided and imaging-guided left main PCI, you can see the results are far better in imaging-guided PCI of the left main. So all-cause mortality after 10 years also is remarkably better in if you do imaging-guided PCI as compared to angio-guided. So side branch, it's a very important parameter to consider, and in that, which device to use. If you have a lot of discrepancy in size of the daughter vessel, it's a reference diameter for the use of the stent. If the discrepancy is more than 2 millimeter, then you need to use a stent which can expand up to 2 millimeter. At the moment, that time the study was done, and study reported that the Onyx Medtronic stent is able to expand, and Synergy Megatron is able to expand. So between the two, I think Synergy Megatron is preferred because it has a highest strength, but advantage with Onyx is bigger cell size. So it allows, after deployment of the provisional stent, it allows easy access to the side branch and allows the various devices to go in. But sometimes we land up with a very challenging case of left main. There are several hemodynamic compromise, patient comorbidity, and very complex lesion with with the calcium and debulking. So that requires a hemodynamic support. And we all know value of impella in left main PCI is tremendous. But if LVEF is low, if LVEF is normal, and you want to still use hemodynamic support, in my experience, that our IABP is good enough to use and gives enough support during the PCI of the left main. Now, what is the future? Future is AI-based left main PCI, and that is not very far. Already Ultron software AI-based is already there in the OCT, and in the OCT soon it will be available in IVUS. And of course, the AI will tell us about the length of the stain, the size of the vessel, and also it will define the value of the side branch. So AI will ultimately help us. So what is take-home message? Take-home message is in low and intermediate syntax score, the PCI is the safe alternative to CABG. The provisional stent for non-true bifurcation and two stent for true bifurcation. And imaging is absolutely strongly recommended and should be mandatory. Use of dedicated large vessel stents are useful to match the size of the end. So what is the conclusion? Conclusion is operator's knowledge is most important if you're doing a two-stent strategy, and experience and judgment is of a paramount importance. Thank you very much for